Yes, we have. Right, we'll just, now my time is 8:02. We'll start at 8:03. We'll just give them 1 more minute. All right. Thank you, everybody. All right, now the time is 8:03. I'll start now. All right. Okay, we do have quite a good number of participants in the list right now. All right, okay. Good morning, good evening, and good afternoon, everybody. Thank you for joining us in the first 2023 APAC ACE webinar sessions. We are pleased to present today's topic, the Percutaneous Drainage Catheter Placement, Determinants for Successful Outcomes by Dr. Jilani. Just a simple house rule, if you have any questions during these sessions, please deposit your questions into the Q&A box and we'll be answering the questions after the presentations. Without further ado, I would like to pass on the time to our Marketing Director, Clint Garnett, for some words before we proceed on with the sessions. Clint, thank you.
Yes, hello everybody, and thank you for taking some time out of your day to join us. We are pleased to have a global audience, and I just wanted to also take a moment to thank Dr. Jilani for his preparation and his contributions to today's discussion. Really, what I'm very excited about in Argon and our day-to-day efforts is in all the presentations that we provide, we always cover our missions and our values. And it's really the drive of all of our employees that builds our day-to-day culture that drives our values and our missions. And so today, I want to highlight the fact that, we want to have great people like Dr. Jilani that we work with, doing things in the right way and showing results that drive up to ultimately our mission of improving the lives of patients and caregivers in everything that we do, from innovating, manufacturing, and delivering best-in-class medical devices. So with that, I'm going to pass this off now to the product manager, Jensen.
Hi, guys. I'm Jensen Winkler. I am the global product manager for drainage at Argon. So I'm responsible for, the drainage portfolio that Dr. Jilani will speak on behalf today. And I know we've all said this, but again, thank you all for, joining globally. It's so cool to see us all come together at kind of all hours of, morning, afternoon, night, wherever we are globally. So this is really special. So again, thank you, Dr. Jilani and the team for, making this happen. So I guess without further ado, I'm excited to introduce to you Dr. Danial Jilani.
Hello, everyone. Pleasure to be here with you today talking about drainage procedures. I know it's not the most exciting topic, but it is becoming increasingly relevant and vital in today's medicine with the push for minimally invasive, low-risk procedures. A little bit of my background, I completed university and graduate level training in Ohio in the Midwest in the United States before completing residency in diagnostic radiology at the University of Chicago, and then went on to Northwestern, also in Chicago, for my interventional radiology fellowship. I worked at a large-sized community hospital for a couple of years outside of training before transitioning into an outpatient-based lab more recently. My scope of career practice has been pretty much wide, with bread and butter procedures, drainage procedures, biopsies, lines, and then a good mix of higher level procedures ranging from interventional oncology, venous disease to pulmonary embolism work. Go to the next slide, please. Just a brief overline of what we hope to cover today. Go an overview of image-guided procedures, look at some of the bench test data, and then how it specifically applies to SKATER drainage catheters and technical and clinical success outcomes. Next slide, please. So image-guided percutaneous drainage or aspiration of abscesses and abnormal fluid collections has become both the diagnostic and therapeutic treatment of choice for a wide variety of fluid collections. The procedures have resulted in reduced morbidity and mortality and have helped reduce length of hospital stay and even hospital costs. The procedures may be performed with ionizing radiation for image guidance. A lot of what we do, including fluoroscopy or CT guidance for many of the procedures we perform. And then obviously non-ionizing radiation as well with ultrasound or MRI imaging. Obviously non-ionizing radiation is preferred when appropriate to minimize the risk of radiation to the patient. For optimal performance of percutaneous drainage, it requires multiple things. A lot of it is the knowledge of the anatomy and pathophysiology of what's going on. Anatomy is increasingly vital with our use of image guidance, knowing where you're going, what path you're going to take, avoiding major structures, blood vessels, and things like that. Familiarity with percutaneous techniques, needlework, wire work, needle placement, etc. And then knowledge of advantages and disadvantages of one imaging modality versus another with any particular drainage procedure or any other procedure. This comes up pretty commonly when you can see some stuff under really well under ultrasound, and then it doesn't turn out to be this case in other times, and you may require CT. So knowing when to flip from one imaging modality to another is very important with adequate drainage. So etiologies are wide ranging, especially for drain placement. A brief overview includes benign cystic disease, renal, hepatic cysts. Infectious causes are a wide margin of what we place drains for, including bacterial, fungal, and other organisms. Post-surgical seromas and lymphoceles are becoming very common as well, especially drainage of these. And then perforation, rupture of leakage from a hollow viscus, so bowel rupture or a ureteral injury during a hysterectomy or another procedure requiring urinary diversion. Anything that causes leakage into the abdominal or pelvic cavity, which would require drain placement. And then collections form secondary to inflammatory states or diseases. An example like Crohn's disease or a Crohn's abscess, a very common etiology. For contraindications for drain placement, there are no real absolute contraindications. Sometimes a patient is so sick on multiple medications to keep their blood pressure up, keep them alive, that you have to intervene no matter what, even if they're platelets or they have bleeding disorder or on blood thinners, etc. So technically, there are no absolute contraindications. If a drain needs to be placed to save a patient, then it has to be done. Relative contraindications obviously include significant coagulopathy that can't be corrected despite replacement, or on blood thinners, severely compromised cardiopulmonary function, hemodynamic instability of patients just not stable enough to come down to your CT scanner or to come down to your procedural area for a procedure. That can be a relative contraindication. And often in recent years, more and more procedures can be done at bedside. It's not uncommon for interventional radiologists to go bedside to do ultrasound guided gallbladder drains, etc. when a patient's too unstable to come down. Lack of a safe pathway or abscess, that's probably the real contraindication. If we just don't have a safe window to get there from the skin, no matter using ultrasound, CT, or what, if there's no way to get there, then unfortunately it's a contraindication. Inability of the patient to cooperate or be positioned for the procedure. Again, we can do a lot of work, especially with the help of great technologists and nurses, to position the patient adequately so we're able to get to some of these collections. And additionally, if the patient is if we're able to give them sedation or some medications to make them more comfortable or relaxed, then this certainly helps in that case as well. And last one would be just a patient refusal of a procedure, which comes up from time to time. So the bench test data that came out, the three most vital things that looked out was outflow, kink resistance, and insertion and tracking force of the catheter itself. And next slide, please. So outflow is the volume of fluid obtained from the hub of the catheter while the pigtail is inserted in a closed cavity. Fluid of varying viscosities, thinking thicker stuff like oil and thinner stuff like water. That was one of the first primary factor tested. Kink resistance was another one. The catheter's ability to bend at a certain angle and still maintain unobstructed patency. Insertion force, which is the force required for the initial insertion of the drainage catheter, and the trackability of the catheter, how well it will track through an organ, through tissue, through anything like that. And then we'll touch back on the data again. Just want to briefly highlight some cases. These are all cases I performed personally myself. They were all showing a wide range of usage of the SKATER drainage catheter in a variety of clinical scenarios. So the first one is a large abdominal abscess. So this is an axial CT scan, contrast enhanced, and you can see a large abdominal pelvic fluid collection. It's kind of displacing all of these small and large bowel loops. So basically all you're seeing here is the abscess cavity, and all of the intra-abdominal and pelvic contents have been kind of displaced. And if you can look, there is actually like a subtle line difference. You can see the stuff layering down on the bottom is a little bit different shade than the stuff layering on the top. And when we show you the corresponding ultrasound image, you can kind of appreciate that a little bit better. So clinical presentation for this patient was abdominal pain, fever, elevated white blood cell count. And to quickly recap, this is a CT scan, contrast enhanced axial image at the level of the pelvis, showing a fairly large, I would say up to 15 centimeter abdominal pelvic fluid collection or abscess. The next slide shows that ultrasound image intraprocedurally, and here you can kind of appreciate the dark stuff on the top left of your screen is just kind of simple fluid. That's the stuff that was layering on top. And then the bottom is that complex debris fluid that was on the bottom of that CT scan. Next one, please. So both ultrasound and fluoroscopic guidance were used to place the drain. A needle puncture was performed under ultrasound guidance into the fluid collection. A wire was advanced, and then over that wire, a SKATER drainage catheter was placed. Since this was a little bit thicker of a collection, we saw that complexity. We went straight to 12 French drain to have adequate drainage here. This is a follow-up scan, just less than 8 days after initial placement of the catheter. And now you can basically see all of the intra-abdominal and pelvic contents. They're not being displaced. That large enhancing fluid collection we saw previously is no longer identified. You're not even really seeing any residual abscess cavity. And then the arrows are pointing to our drainage pigtail catheter in the left lower quadrant. So important point of these, both the bench data showed and also just anecdotally using the catheter, drainage flow dynamics is vital here. So if it doesn't drain as fast, which SKATER has been shown to do, these fluid collections could linger for weeks to months at a time, and that's not uncommon. We see that pretty commonly. Some collections just become chronic over time. So the faster you can get this drained, the better clinical outcome, lower hospital costs, etc. Case 2 is a malignant obstruction from a urinary bladder mass causing right-sided hydronephrosis. So this is a coronal contrast-enhanced CT. On the top left of your screen, you see the kidney, and the arrow is pointing at severe hydronephrosis. And then the bottom arrows, 2 arrows, are showing abnormal urinary bladder thickening. So the urinary bladder thickening corresponds to malignancy, causing obstruction of the right kidney, backup of the right kidney. Patient had elevated creatinine, and her renal function was worsening prior to placement. So they presented with us. Urology was not able to place a stent retrograde through the urinary bladder. Next slide, please. So it's an intraprocedural image, again, using a SKATER drain under ultrasound guidance. We stuck a posterior and inferior calyx with significant hydronephrosis, again, identified intraprocedurally with contrast injection. And same technique as always, hit it with a tiny needle, passed a wire through, and over that wire had no issues with trackability of the SKATER drain. This one was an 8 French. I find with urine, it's not very thick. Often urinary catheters, especially when they're chronic indwelling catheters, can form sediment and things like that, that can cause obstruction and not drain well. But both the drainage flow of the SKATER catheter, I have not seemed to find the same results with that. The drainage flow is so adequate, and there's so much kink resistance that these patients do really, really well. You don't see as much sediment obstructing the catheter, and you don't see as much kinking as well. So kink resistance is essential for patients with chronic and long-term drainage catheters. Some of these patients, we like to try to get out to 8 to 12 week follow-ups when they present for their exchanges. And having a catheter you can rely on that drains well, does not kink, does not obstruct, really allows us to push this time frame out, whereas other areas bring back patients 4 to 6 weeks sometimes for drainage catheter exchanges. Case 3 is a chest tube placement for empyema or infection. Historically, I feel like large bore chest tubes were often placed for infected collections in the chest. And those things can reach up to anywhere from 16 to 24 French. They're big kind of garden hose type of drains. This patient presented with hypoxia and fever. And then there's a chest radiograph here. Shows a complex, it says bilateral pleural effusion. So the left one is more complex, loculated at the left lung base. And the patient came to us, was a poor surgical candidate. We were asked to place a drain in there for an empyema. So again, similar technique under ultrasound guidance. So we identified the pleural fluid, put a needle into it, and subsequently a wire and drainage catheter. The patient subsequently improved after large volume drainage over several days. And what's interesting here is the jump for surgical drainage to be large bore. As I alluded to, oftentimes it's anywhere from 16 to 24 French. These are very, very big catheters, can be very uncomfortable for the patient. And what we found is just sometimes is placing as an 8 French drain is enough to get everything done. Even if it's a thick or complex fluid collection, an 8 French drain can adequately drain infected fluid collections very quickly. And you don't necessarily need to jump to a huge bore catheter. I mean, with this, we didn't even need to, very rarely do we sometimes go up to 10, 12 French drain chest tubes if there is poor drainage. But for something like this patient did very, very well with just a small bore 8 French chest tube. And then for this, chest tubes are very, very prone to kinking, especially when they're larger bore or the angle you take and things like that, going intracostal with the ribs. So having a reliable catheter that can adequately drain and have kink resistance, again, proves to be vital. Right. Case 4 is a percutaneous drainage of an infected gallbladder, acute cholecystitis. So back when I was in med school, I felt like acute cholecystitis was always managed surgically, either laparoscopic or open cholecystectomy. And then in recent years during training, it became increasingly utilized for a percutaneous cholecystostomy tube. And then out in clinical practice, I feel like this was very, very commonly encountered. We would be asked by surgeons several times a week to place a cholecystostomy tube or a gallbladder drain for cholecystitis. And often, sometimes they would be non-operable candidates, but even just to curb the inflammation. That's the recent trend I've been seeing, is that surgeons have been asking for us to place drains to allow the gallbladder and the inflammation to cool down. And then they take them back for a cholecystectomy at a later date, 6 to 8 weeks down the line. So clinical presentation of this patient, obviously acute cholecystitis, right upper quadrant, epigastric pain, fever, elevated liver enzymes. This is an axial CT image without contrast. And on the right side of your screen, you're seeing a moderate distension of the gallbladder. And on the right side of the patient, left side of the screen, you're seeing the fat surrounding the gallbladder demonstrating fat stranding or inflammation. You see a very small punctate, high density calcification, likely representing gallstones. So clinically and imaging consistent with acute cholecystitis. This patient was 94 years old, so it was a very poor surgical candidate, which we were asked to place a percutaneous drain for. This is an ultrasound image intraprocedurally, and the echogenic bright line you're seeing is the needle going into the gallbladder. And again, you kind of see that complexity we saw in that prior abscess case where there's some dark, simple fluid, and then there's some layering complexity, gallbladder sludge or gallbladder stones also there as well. And the next slide, please. So as a rule, general rule in IR, we're always taught you should never have to use brute force. If you do use brute force, you're doing something wrong. And this kind of speaks to the insertion force and the trackability of the SKATER catheter. When traversing parenchymal organs, less insertional force and optimal tracking force leads to improved technical success. And by not having the jam catheter through the liver, that has a lot of blood vessels, hepatic veins, portal veins, hepatic arteries, you limit harm and risk to the patient as well. This is a great image because it shows how well this catheter kind of coils up in the gallbladder. So it's an intraprocedural fluoroscopic image showing the percutaneous cholecystostomy tube. And then contrast was injected, confirming that the cystic duct was obstructed. And you're seeing contrast pooling in the gallbladder there. Case 5 was again a chest tube placement, just a little bit different of a reason. There's a patient with COPD or emphysema that presented with chest pain and was found to have a spontaneous pneumothorax. And again, historically, a lot of these, when they go down the surgical route to thoracic surgery or even general surgery, they usually place large bore chest tubes. In recent history, now with emergency doctors, interventional pulmonologists even placing chest tubes, there has been an increasing trend for small bore pigtail chest tubes to manage both pneumothoraces and infected fluid collections in the chest. So this is a chest radiograph. It doesn't come across great on the screen, but these arrows are pointing to the pleural line. You can see that the right lung is collapsed and it's generally darker outside, peripheral to the line. You're seeing absence of pulmonary vascular markings and markings that indicate a moderate sized right pneumothorax. And then this is a subsequent chest radiograph after a pigtail chest tube has been placed. Again, going in with just a small bore 8 French chest tube, especially for pneumothoraces, with just evacuating air, has been shown to be very, very, very effective. And this is immediate resolution of the pneumothorax as soon as that percutaneous chest tube was placed. So again, touching on the results and conclusions of the study, SKATER drainage catheters demonstrated the greatest outflow and kink resistance in comparison to the catheters of the same length and French size. Having the opportunity to train at multiple institutions in Chicago, I've actually gotten to use basically every catheter on the market almost. And I'll be honest, initially when I came across SKATER, I wasn't too familiar with it. I wasn't familiar with the mechanism, the locking mechanism, and the drain in general. But after using it multiple times, there's definitely some superiority compared to other catheters on the market. And the things we see, could you go back a slide, please? Sorry. And again, I just want to harp on this: greater catheter outflow, kink resistant, and lower insertion force are definitely things anecdotally we see as well on the clinical side when using the catheter that works really, really well and has shown improved patient outcomes. The next slide just demonstrates the catheter itself, the locking mechanism up top, the pigtail, the large the large holes for drainage flow, and then the position markers to kind of measure where you're going. Pretty much very similar to other things on the market, but at the same time, very, very different in the subtle nuances of the catheter itself. So I feel like these cases best illustrate why I feel pretty passionate about SKATER as a drainage catheter. The recent data just confirms kind of what we've been seeing clinically in our practice. It obviously focuses attention on these factors, kink resistance, drainage flow, but what I think is really, really special is the versatility of the catheter itself. A lot of catheters can't be used for everything. This catheter can be used for even sclerotherapy when we're trying to irritate a lymphocele or a seroma, where you can use toxic chemicals like dehydrated alcohol and things like that, which with other catheters may burn the contents of the catheters. So it's great that these cases kind of demonstrate how it's used head to toe throughout the body, and it works very, very well. And we see very, very good patient outcomes. And you don't even have to worry about the compatibility of it. You know that it's going to work in pretty much any scenario you need it to work. Again, this kind of harps on what we just talked about. The all-purpose suitability is what I think is one of the most underrated factors about this catheter. The ability to put it in anywhere, pneumothoraces, infected fluid collections all over the body, into the kidney, into the gallbladder, and to postoperative collections. I've even placed it into the urinary bladder as a substitute for a suprapubic catheter as well. And happy to take any questions. I think we have a few already. Is that correct?
I guess I can, start. We had a question come in talking about discussing the use of drains for an ideal conduit procedure, and include thoughts on the gauge size and your the catheter length selection.
Oh, sorry, Jensen, I didn't hear you too well. Could you repeat that?
Oh, sorry. Basically, when you're going into a conduit procedure, what are your thoughts on gauge size and centimeter length? How do you approach picking which size drain to use?
So in general, I think there's also a question about whether to use an over the wire approach or direct stick approach. So I can kind of touch on this on there as well. My general approach for percutaneous drainage is one, finding the best window away from any blood vessels, and away from any vital structures, away from anything that can go wrong. Mapping out where I want to go in, whether that's under ultrasound or CT guidance. And then I basically judge what gauge needle to use and what French catheter to use based off what risk I perceive happening. So if the collection is only a few millimeters away from any major blood vessels, and instead of going with a larger 18 gauge needle for initial placement, I'll go with a 21 gauge micropuncture needle to minimize those risks. So I feel like the smaller gauge size you can go, the smaller French size you can go on a catheter, the better clinical outcomes, the less risk it is for the patient. So vast majority of my cases are all performed with a 21 gauge needle, a micro system using an 018 wire, and then obviously transitioning into an 035, dilating up for placement of a drain. That said, there are many times where I will go with an 18 gauge if I feel like it's a huge, big fluid collection. There's not much things around that, not many blood vessels, there's not bowel, there's not other organs that I'm worried about. Then I will direct puncture with an 18 gauge and then stick with an 035 system right from the bat. It cuts off a few minutes of time. But honestly, I found that there is no wrong answer, but a right or wrong answer, but always going with the smaller gauge tends to minimize any further risks to the patient, most commonly bleeding. As far as what size to use, I'm general. Again, I tend to go lower bore until I need to be shown that I need to upsize it at all. So there are times where there's not adequate drainage or there's a blockage or something like that, where we may need to upsize to 10, 12 very rarely 14 French. But I showed you all these cases from head to toe. The vast majority of my cases, I placed 8 French tube into the nephrostomy tube, into the gallbladder, into the chest, and patients recover very fast and have great clinical outcomes. As far as direct puncture, I do think there is a role for a direct stick approach using the needle that comes with the SKATER catheter. Again, it's a bigger of a needle, and the risks associated with that are a little bit higher. I alluded to placing a suprapubic catheter into the urinary bladder. That there have been times where I've used a direct puncture stick approach, basically trocar technique, just using the SKATER needle with the drainage catheter and feeding off the drainage catheter directly into the bladder. Just because you know exactly where you're going. When you go midline, there's no blood vessels on either side. But I will say it does, even though it can go very, very simple, it can be associated with increased risks. So even if you do everything right, a case comes to mind from a couple of years ago where I placed a suprapubic catheter on a patient who was on blood thinners. Again, I went midline, away from any of the inferior epigastric blood vessels. Everything went very, very smooth, and then I got called in the middle of the night that she wouldn't stop bleeding. And what had happened was that I did do trocar technique, and what happened was there was a body wall collateral, small vessel that was right superficial, right next to the skin, that was either injured or nicked during the placement. So it was a simple fix, a purse string suture. It was a superficial vessel that was just tied off very, very quickly, and the patient improved significantly very fast. But she needed to get blood transfusions because she lost a decent amount of blood. And it was associated with more complications than I would have liked. In retrospect, although I think it went fine doing a trocar approach, I do feel like personally, if I had gone with a 21 gauge micropuncture needle and done the conservative approach, that it may have alleviated some of those bleeding risks.
All right, thank you. We do have another question as well. Based on one of the case presentations that you presented earlier on, could you provide the cost of the large intra-abdominal abscess? What could be the cost factors?
I believe it was a bowel perforation. The first case with a large abdominal pelvic abscess, case 1.
Yes. So it's okay, perforations. Thank you. Just I'll take the next questions. Okay, you have used different types of drainage catheters. What has your experience been in terms of the improved patient's outcomes when you use various kind of catheters? So, based on your experience, what are the improved outcomes when you use the SKATER catheter?
Sure. So I feel like what's really good here is that what the data tested, what was tested has shown to be kind of clinically applicable. So these factors, the greater catheter outflow, it has been shown to be very, very effective compared to other catheters. Kink resistance, lower insertion force. These things is what we see clinically as well. So for example, I brought up the nephrostomy tube. A chronic nephrostomy tube. I've had issues with multiple other drains. A certain one drain on the market is very notorious. If the thread is not cut correctly, then there's leakage at the hub. And this was something I saw in fellowship come back on a weekly basis, that a patient would come back with continued leakage around the hub of the nephrostomy tube. And it was notoriously always the certain drainage catheter that was out in the market. So things like that actually may seem little inconveniences, but down the line, add them all up, all leads to basically improved healthcare costs, increased healthcare costs, increasing time of both the clinician and the patient, for the patient to come in repeatedly for these things. So that having these factors, kink resistance, and not being obstructed, not leaking around the hub, these things have been shown to be superior compared to other catheters. Insertion force, as I alluded to, is gallbladder drains. If these are gallbladder or even chest tubes, these are prone to kinking. If you can prevent these kink resistant things that happen with other catheters, you're able to drain whatever fluid collection or pneumothorax faster, and you're able to improve the patient faster, I truly believe. Yeah, I'm a firm believer in draining an infected collection, particularly as fast as possible. I mean, I've seen patients improve clinical status near instantaneously in many cases, especially with backed up cholecystitis or hydronephrosis in the kidney. Relieving that obstruction and infection can take somebody off pressor support within minutes. It can get them out of ICU hospital stays and really shorten their overall stay, but getting them out of the hospital stay within a few hours after the procedure, where they were there for several days leading up to it, trying to find the etiology of why they're in the unit. And then, for example, draining a pneumothorax, healing the lung, not having to do multiple catheter exchanges, being able to drain a pneumothorax, heal a lung within 24 hours versus several days, cut costs dramatically, and it just leads to more downstream effects. Patients being required to take, if it's not resolving quicker, then there's a lower threshold for surgeons to jump in there and be a little bit more aggressive.
Thank you. Another question came in. Could you share examples of where longer drains, like 60 centimeters, might be needed?
One would 60 centimeters is pretty long. I don't know if it mostly just be for if in bigger patients. Unfortunately, it's more of a problem in the United States. We have with the obesity problem, a lot of our patients are very, very large. There have been many times where I'm placing a cholecystostomy tube or a gallbladder drain, and my drainage catheter is completely hubbed at the skin. And there's not even much room to tie it down to the skin. So I do see longer catheters being very, very beneficial when there's just a long track to get to where you're going. A gallbladder is definitely a prime example of that, because we try to go through a portion of the liver to get there. And with these patients larger and larger, we can have a track to get there of at least 35 centimeters. And then some abdominal fluid collections, the majority of which I think are the majority of procedures overall. I think standard length catheters will do the trick. But there certainly are instances where the track, or just to get there, is so long that a 60 centimeter catheter would help. Certainly if you're trying to coil the catheter within the collection, it can be very vital in patients where the catheter repeatedly falls out. So you see this with gallbladder drains as well. You see it with drains all over the body when there's not a lot of purchase, that they will fall out. So if you're able to place a longer drain, basically coil up the catheter as much as possible within that drain, and this is where kink resistance really comes in handy, because as you saw in that gallbladder, I'm able to put 20 centimeters of that catheter into the gallbladder, and it coils up very nicely, doesn't kink, and it stays in there long term. So particularly with patients with long-term drainage catheters, I think it's more beneficial that it would, yeah, somebody is saying urostomy, that also works great for that as well.
All right. Thank you. So another question as well. When and where would you prefer to use a mini loop catheter versus a standard loop catheter?
Yeah, so a mini pigtail catheter is great. Correct me if I'm wrong, I believe it's indicated into collections about as low as 1.5 centimeters or less, whereas the standard pigtail, you need about 2.5 or 3 centimeter collection for the standard pigtail to form. So the mini pigtails are great for these tiny collections, and you'd be surprised. As collection, you would say 1.5 centimeters or less than 2.5 centimeters is a pretty small collection. Does it really need to be drained? But patients are still surprisingly very symptomatic sometimes from these small collections, and it needs drainage. They've been persistent. It won't respond to antibiotics, things like that, which does require sometimes a drainage catheter. So these mini loop drains are perfect for that, because they can fit into a very, very tiny collection and then drain very, very well. Whereas a normal conventional drainage catheter, the pigtail won't form within a collection that small. It's also, I think, beneficial if it's a very kind of high risk collection or it's near multiple vital structures, things like that, using a little bit smaller bore catheter, a smaller pigtail. It will work well just to get into these kind of trickier collections.
Thank you for answering that. Another question came in asking about for longer term nephrostomy patients. I'm sure you've experienced that, the tip hole could possibly get obstructed and the catheter exchange could be difficult for the physician. In your experience using SKATER, what features on SKATER help prevent that? And then, any tips for, you exchanging your catheters for these long-term nephrostomy patients?
Yeah, that's certainly a factor that comes up with these chronic indwelling catheters. And it's honestly very patient specific. Some patients are just prone to more urinary sediment than other patients. And then this sediment obviously kind of goes into our drainage holes of our catheter and can obstruct them and make routine catheter exchanges very difficult because you can't get your wire to fully unfurl the pigtail. So I would say, anecdotally, in my experience, that these larger drainage holes have really shown effective compared to other drains I've used for chronic nephrostomy tubes, that they're less likely to get urine sediment to obstruct them. I'm not saying that urine sediment won't kind of evolve on the catheter, but they're less I find it less difficult for my wire to still kind of puncture through and get out, unfurl the pigtail for an exchange.
Okay. Yeah, there's one more question. There's another question that came in. What catheter would you use for percutaneous biliary drainage, which is percutaneous transhepatic cholangiostomy?
Yeah, so for that, the problem with just external drainage catheters for biliary drainage is that there's so much volume loss. You're really losing a lot of, in certain patients, they can lose a lot of biliary fluid each day if it's just an external drain. Now, sometimes there's essentially obstructing cholangiocarcinoma or essentially obstructing mass where you're not able to get down into the small bowel or past the common bile duct, which requires you to place just an external drain into the intrahepatic biliary system or near the porta hepatis. But ideally for these patients, the best thing would be an external biliary drain with both with internal side holes as well. And that allows both adequate drainage to allow internal drainage, and then there's still some coming out into the bag if it doesn't adequately drain. And these patients do really well because you're minimizing the loss of fluid from these patients, minimizing third shifting and fluid shifts throughout the body with external biliary drainage. Obviously, if a patient can undergo metallic or plastic stent placement, those are also really good options as well. But as far as on the drainage side, my preference is always external biliary drain. And then if that's not feasible, then an external drain.
Thank you. I think we have time for one more question. So for chest drainage in a pneumothorax, what connection is used to link the drainage catheter to the bottle or the drainage bag?
So in our experience, at least, every chest tube we place is attached to a Pleurovac device. And all that is just standard. One attachment will attach onto the end of the drain, just like it normally would. It's a lure lock kind of system.
Thank you. There's a few other questions coming in. Sorry, no.
No worry, we have time.
Okay. Who removes the inserted or who removes the catheter? In your practice, is it the IR or the primary team, or do you have scrub techs, nurses, etc.?
Yeah, that's a really good question as well, because it is kind of institution dependent where you're at. When I was in training at University of Chicago, we placed the drain and then we basically never saw the patient again. The ordering clinician or usually a surgical service would take over management of both the drain and removal of that drain. Very rarely would a patient really come back to us. In training at Northwestern, things were handled very, very differently. We would bring back the patient every 2 weeks for an abscessogram and inject the drainage catheter, show a cavity, and then kind of figure out management from there. And then out in practice, it's kind of the push for interventional radiology recently has become more and more clinical. To have a clinic, to see patients, to manage your own drains. So out in clinical practice, I do personally manage my own drains, and we bring them back for follow-ups. We both use CT and fluoroscopy, mostly CT, just because it provides so much more information. Oftentimes, when we're worried about a fistula, we'll inject the drainage catheter and show if there's a fistula at the colon and things like that before pulling a drain. So it's kind of wide ranging. I generally don't have techs or nurses pull the drain. I do have an advanced nurse practitioner sometimes do it, or I'll do it myself.
All right, thank you. Okay, last questions. Drainage care for you and for the nurses practicing. In the case of abscess after surgery, how often do you need to flush the catheter?
That's a really good question as well, because you ask 10 different IRs, you might get 10 different questions. I generally judge flushing a catheter based off how viscous the abscess or fluid is. If it's like a pus-like collection, a diverticular abscess that's very, very thick, that I think may end up obstructing a drain, I ask them to flush it 5 times, twice a day. If it's something that I think is not very viscous, just kind of serous-like, then sometimes I just do 5 once a day. And then there are times where I don't think there's going to be any issues at all with the catheter obstructing, that I don't instruct flushing at all sometimes. Classically, like cholecystostomy drains or biliary drains, you don't want to flush with all the native bacteria and stuff that's in the biliary system that can cause transient sepsis and things like the transient bacteremia, things like that. So in general, if it's a very, very thick collection, then I advocate for more vigorous flushing daily. Whereas if it's not a very thin collection, then sometimes you don't even need to flush it.
All right, thank you. We'll love to have more questions coming in, but we are running short of time. So if you do have any more questions, please feel free to send the questions to your respective sales rep or country managers, and we'll be happy to direct the questions to all the medical expertise. So with this, we would like to give our heartfelt thanks to Dr. Jilani for today's amazing presentations, to Jensen as well, to Clint, as part of the opening speech for our APAC ACE program. Thank you, Dr. Jilani, and do stay connected with us on our Twitter, our LinkedIn, as well as our Facebook. We'll be having much more of such programs ongoing, and we welcome everybody to join us again. Thank you so much.
Thank you. Piggybacking off of Chris, again, thank you guys all for participating. Such a great event. I think I can speak on behalf. It was very informative, very, great to hear from you, Dr. Jilani. So thank you again. So I hope you guys have a great rest of your day, evening, whatever time it is there. And again, feel free to reach out to either myself or Christopher if you guys have any other questions.
Thank you so much.
Thanks, everyone.
Thank you so much, everybody. Have a good day ahead.